So this is Geriatric Summative presentation part 3. We have delirium and dementia to talk about. Delirium is an acute state of confusion. It usually happens suddenly over a shorter period of time, but it can happen over a longer period of time and is usually related to biological or psychological stressor. Cause could be stroke, tumor, infection, fluid and electrolyte balance, acute inflammatory disorder like UTI that can cause systemic infection, a drug reaction or toxin, sensory deprivation or overload. Dementia refers to an acquired persistent loss of intellectual functions due to a brain disorder, which is not a normal part of the aging process, even though the vast majority of persons who experience dementia are 65 and older. Dementia is really a broad term, and a medical diagnosis is required to determine an underlying cause or causes of symptoms. In the past, people used terms like senility or hardening of the arteries in the brain to describe dementia, but those terms are not really accurate. Dementia is really a permanent condition that's characterized by severe cognitive deficits. Its onset is slow and can be caused by Alzheimer's or brain tumors, some other serious medical or surgical disorders. Symptoms are not well described, but characterized by several cognitive deficits that affect memory, intelligence, problem-solving ability. The symptoms can also mimic depression and delirium. We see some other behaviors in older adults, whether they have dementia or not. One is wandering, so they might have a cognitive disorder, but maybe they were just formerly very active and goal-oriented and they're looking for something because they're bored. So making sure that they have a safe environment, they're wearing an ID bracelet in case they lose their orientation to person, that they are checked on frequently. If they're living home alone, that somebody is calling or talking to them once a day, identifying their triggers to wandering, and maintain a regular schedule. Sometimes they might need an alarm or wander guard. We have sundowners, which is a acute confusion at nighttime. The cause is unknown. We could add a night light, do most of our activities in the morning or earlier in the day when the client is fresh, decrease the caffeine in the PM, decrease naps during the day and reducing environmental stimulation, especially at that time of day, keep the call light within reach, and create a soothing environment, something that's familiar to them, whether it be music or familiar voice type of things. You also want to assess and make sure that they don't have electrolyte imbalance or infection. Depression. Older people have multiple losses. They can lose status and power. Their finances can change. They can have declining health, or a long-term partner has declining health or loss of that partner. They often need some psychotherapy, hospitalization if they become suicidal. They have medications that can help, or even electroshock therapy can be helpful with older patients. We also need to look at alcohol abuse in our elderly patients. If they're using inadequate coping mechanisms, we might need to address that behavior as well. Some interventions we can use, you may have seen some in clinical. One example is reality therapy to reorient the client back to person, place, and time, having a regular schedule and memory aids such as cueing the room, labeling things. Validating therapy, which can help promote self-esteem and communication. It can reduce stress, and they might want to do activities that they like, singing, art, drawing, puzzles, looking at photos. And then we have reminiscence, which can really help reorient somebody who is confused and irritable. And looking at the past, they remember the past better than the present, and it can give them some stimulation and really leads to that integrity stage in Erickson's model, and can help calm them down if they are irritable. We can look at remotivation, which can stimulate and provide new motivators with facts, new experiences. So pictures of animals or art or music that they like is a great way to intervene. And then we have resocialization, which is involving a client in a group activity. So it could be a group project, playing a game. Sometimes in the nursing home, you might see a ring of clients sitting around and they're tossing a ball to one another. Then we have some pharmacological interventions. And we would only use these drugs after behavioral and other nursing interventions have failed. And obviously these would be dependent interventions that you would collaborate with the care provider, and you would look at some maybe tranquilizers or antidepressants. Sometimes anti-anxiety or even anticonvulsants can provide that symptom relief. Remember that we are required to report elder abuse, and usually in the acute care that would mean contacting a nursing supervisor and or a social worker to help you with the next step to do that. If you are in a home care situation, it could be that you're contacting a county health department for that. But any intentional infliction of physical or emotional discomfort or a deprivation of basic needs, whether that's intentional or not, and it could be caused by caregiver stress, role strain, family conflict, or even lack of communication, family history of abuse. So please look at the different categories: physical, sexual, psychological, material, or neglect. And remember, we are promoting that, or I'm sorry, identifying that to the authorities if we see any of those categories of elder abuse. This is the end of the geriatric summative presentation.